Well, thank you for the opportunity to tell you a little bit about urologic surgery at Washington University in St. Louis. I'm Jerry Andriole. I'm the head of urology here, and it really is a pleasure to get to know you guys later on when we have our face-to-face Zoom meetings. Welcome. This is a snapshot of the group a year or so ago, and I think you can see they were pretty good camaraderie and a nice group of faculty and residents there. Many of you, or even your families, probably don't know anything about Washington University in St. Louis. You know, many people would think that we're either in Washington, D.C. or the University of Washington in the state of Washington. There are actually something on the order of 35 to 40 institutions of higher education in the United States that use the word Washington in the title. So our official title is Washington University in St. Louis. And WashU describes itself as a medium-sized research university of about 16,000 students. We're fortunate to have a nice-sized endowment of $8.13 billion, could be higher today. Stock market seems to be going up, which is overall 12th in the United States among universities. Our medical school is 4th in federal funding, and you can see the dollar amount there. And we have the 3rd largest academic clinical practice group in the nation, with about 1,400 physicians, 76 specialties, and well over 1 million outpatient visits per year. Now, in the Division of Urologic Surgery, we really are committed to taking care of our patients and to teaching our trainees. And so about 15 years ago, the faculty and I developed a mission statement for urologic surgery. And you could see it here, but I think it's worth repeating. I mean, our goal is to care for all patients with compassion and skill, and furthermore, to improve the care of tomorrow's patients through the research that we do and the teaching that we do. And that's why we highlighted teaching, because that's going to be especially pertinent to you guys when you come here for your residency training. Furthermore, each of the faculty at WashU, when they join the faculty, sign this particular statement. And in the interest of time, I'll just go to the middle bullet there. And this is applicable to our students and our residents and fellows, recognizing that we preside over the transformation of our trainees into urologists, a process that can be arduous and stressful. We strive to be patient teachers, to listen always to their concerns, and to expect excellence. And I just mentioned these two things because we really do have a sincere and ubiquitous among all the faculty commitment to teaching. And that obviously is important for the residents, and it's important for our students and fellows. Now, a little bit of history about Washington University and urology. The first head of urology was a man named John Kalk. He came here in 1910 from Johns Hopkins. And you can see he served for 29 years. I will say his first trainee arrived in 1921. So we are planning to have a 100th year celebration of resident training next year in 2021. John Kalk was famous for developing a device referred to as the Kalk punch. It was a blinded way of shearing off the middle lobe of the prostate. And he was the founding member of the Clinical Society of Genitourinary Surgeons. He was succeeded by an individual named D.K. Rose, and you can see his years of serving. He is credited with coining the term cystometry, and he developed the first clinical cystometrogram. He was followed by a man named Justin Cordonnier, who did urinary diversion. He was working side by side with a general surgeon here named Eugene Bricker. And between the two of them, they developed the ileal conduit. Justin Cordonier, for what it's worth, always felt that the sigmoid colon was a little better than the ileum. But I think the ileum for many years was the preferred source for cutaneous urinary diversion. Justin Cordonier was succeeded by Saul Boyarsky for just a few years. He developed a early symptom score for BPH. In fact, one or two of his questions are in the AUA symptom score for BPH. Then his successor for a few years was actually a private practitioner named Robert Royce. I am the Robert Royce Distinguished Professor of Urology. And that's because Robert Royce, although he was not an academician, was a resident favorite. And he really had such a large practice and was such an affable guy and such a good teacher that trainees for many years recognized him as a really crucial person in the development of their careers. Bob Royce was succeeded by a man named Bill Fair, who came here from Stanford. He left a few years later and went to Memorial Sloan Kettering in New York. And then my immediate predecessor was Bill Catalona. And Bill will either be credited or blamed, depending on how you look at it and how time plays out, for PSA-based screening of prostate cancer. So that's just a little bit about our background from the point of view of the heads of urology at WashU. I will say I'm very proud of this slide. Over the years, quite a significant number of individuals I've shown here have either been residents, fellows, or former faculty members here and have moved on to leadership positions in a variety of academic medical centers throughout North America. And I think this is a value for our residents because there's a built-in network that that individual could take advantage of when it comes time for you to either search for a fellowship or to search for your first job on an academic faculty. Now, I am very proud of the fact that we have a large and a diverse faculty in urology. All of our faculty members are fellowship trained. In the interest of time, we've grouped the faculty into some of the sub-disciplines. So I'll just start with oncology. Here I am, Eric Kim, a former resident and fellow here. Jason Frankel came to us from the University of Connecticut and Virginia Mason Medical Center in Seattle, Washington. Lewis Thomas from Iowa and the Cleveland Clinic. Arjun Sivaraman did his medical training in India and then 2 fellowships, one at Institut Montsouris in France and then another at Memorial Sloan Kettering. Zach Smith from the University of Pennsylvania and the University of Chicago. We are very strong, as you know, in oncology, but not to say we're weak in endourology. The next group here, Sam Baiani, you can see trained here at WashU and Johns Hopkins. He also serves as the Chief Medical Officer for the Washington University Faculty Practice Plan. Alana Desai has a practice limited nearly exclusively to stone disease. Kifu Du does all aspects of minimally invasive and robotic surgery, and you can see his training background there. Sherb Fegenshaw has been around here almost as long as I have, and he does minimally invasive and robotic surgery. Charlie Nottingham came to us from the University of Chicago and Indiana University. Practices all aspects of endourology, and particularly fairly recently has brought the HOLEP, holmium laser enucleation of the prostate, to our practice here. Also in endourology and minimally invasive surgery is Ken Sands. You can see his training background. And Venki, again, who did some of his medical school and training in India, and then fellowship at Washington University. We have a nice group of faculty who focus on men's health. Chris Arrett takes care of all aspects of men's health and general urology, and particularly green light laser ablation of the prostate. In fact, he was recently awarded the stature of a center of excellence for laser ablation of the prostate because of his high volume and his excellent results. Arnold Bullock does general urology, erectile dysfunction, and oncology. He still is one person who will do an open prostatectomy. So if you have any hankering to learn how to do an open prostatectomy, Arnold really is very, very skilled at that. Dane Johnson, you can see he came to us from the Medical College of Wisconsin, takes care of male infertility and all other aspects of men's health. We have two faculty members in reconstructive urology, Craig Murphy from the University of Connecticut and UCSF for his fellowship, and Gino Vrasella from Case Western Reserve and pediatric urology fellowship and some reconstructive urology training here at Washington University a few years ago. Henry Lai does female urology and neurourology, and you can see his background is from Baylor College of Medicine. Also in general urology is Sunil Apte, who's been around longer than I have, and he's just a real asset for taking care and managing patients in an office setting. Chris Arrett, we already talked about. And Ralph Torrance, in addition to being a general urologist, also serves as the head of urology at the St. Louis VA. And as you'll see, the VA is an important part of our residency training program. We have three pediatric urologists. Doug Copeland is the head, and you can see he did his fellowship training at Children's Hospital of Philadelphia. Erica Traxel, she's fellowship trained at Cincinnati Children's Hospital, and as you know, she is the residency program director. And again, Gino Vrasella, you met him earlier, is a pediatric urologist. He does reconstructive urology on the adult side, and he also heads up a transition clinic for pediatric patients transitioning to adult care. We have two full-time researchers, husband and wife, devoted to prostate cancer. And between the two of them, they have a couple of RO1s. We have a spore application under very mature development that we'll be submitting soon. But they serve as a basic science mentor to a number of the faculty and to certain of the residents. Because although they focus on prostate cancer, they're very good scientists, and they understand how to think scientifically and how to advise trainees who might be interested in that aspect of urologic training. Now, were you able to fly here, as has been the case for many years? You would have flown into the Lambert International Airport, which is located sort of in the top right of this diagram. The Mississippi River is shown here. The Arch and downtown St. Louis and all the sports museums, sports stadiums are located right here next to the river. Washington University and the medical campus is in this dashed box right here. And then there's a blow up here showing that the medical campus is on the eastern side of what's called Forest Park, and this is said to be the largest urban park in America. And then catty corner to it on the other side is the undergraduate campus of Washington University, which we also refer to as the Danforth campus. Here's what it looks like on Google Maps. So the medical center is here. You can see the park in between. It's a very nice park. There are 3 or 4 golf courses. There's the art museum, the zoo, the St. Louis Science Center, the History Museum. There's a lot of biking trails, running trails, and baseball fields and the like. And it's a really nice, safe place to spend some time. Now, here are the key facilities for the urology residency. So there's Barnes Jewish Hospital, St. Louis Children's Hospital, the John Corcoran or the St. Louis VA Medical Center. There's Barnes Jewish West County Hospital, and there's Christian Hospital. And you can see the various logos associated with those institutions. I am sitting right now at the main medical center. And so if you remember that Google snapshot I showed you, this is Forest Park over here. The hospital buildings front the street right here, which is called Kings Highway. The medical school buildings are right behind there, and they extend for 3 or 4 blocks behind the hospital buildings, which front this Kings Highway Boulevard. And just for orientation purposes, I'm actually sitting in this building right over here. We do our surgery and have most of our inpatients in this building here, which is brand new, called Parkview Tower. And also, if you look very carefully at my background, the Siteman Cancer Center building. This building here is empty and is starting to be torn down, and within 2 years, there will be a cardiovascular hospital to replace it. So the facade of the medical center, if you were to look at it from Forest Park, looks like this now, but within 2 or 3 years, it's going to look like that. This is just a reminder for me to say that we have a level 1 trauma center. And for those of you who might be interested in trauma, you'll get plenty of trauma and gunshot wounds and the like. Now, we have a number of off-site, if you would, that means not on the academic medical campus, places where the faculty practice and where the residents train. So the first one I want to point out is St. Louis Children's Hospital Specialty Care Center. So remember, if you look at this Google map, the academic medical center is here. If you journey 12.5 miles out this way, basically due west, you can see where this clinic and outpatient operating rooms are located. I would say our pediatric urologists do somewhere between 20 and 30% of their cases at this location rather than at Children's Hospital, which is down here. Here's a picture of the St. Louis VA Medical Center. All the VA medical centers pretty much look like that. And again, here's the academic medical center. If you focus on the Google map below, it's about 3 miles due east of here. It's very, very close and easy to get to the John Corcoran or St. Louis VA Medical Center. And as you'll see, this is an important part of the residency training program because it's very high volume. They have a robot. Many VAs throughout the Midwest are closing. Consequently, there's a lot of referrals for high-level urology care that are sent to our VA. And it's a beautiful, beautiful place to train. Barnes Jewish West County Hospital, again, back to the Google Maps, is located about 14 miles due west of here, a little bit north of where that children's specialty clinic was located. It's a brand new hospital out there. I do all of my surgery at Barnes Jewish West County Hospital. Patients love it. It's easy to park. It's easy to get in. It's easy to get out. All the specialties are there. And also particularly for clinical research, as we'll get to, we do a fair amount of clinical research trials. And many of those trials have fairly frequent visits, for different tests and checkups. It's just a lot easier for the patients to go to a venue like this than it is to come to the academic medical center, where you have to park a few blocks away, walk a bit, and find your way between, the 30 or 40 buildings that comprise the medical center. And Christian Hospital, again, another important part of the training program, is about 12 miles due north of the academic medical center. And it also is a very important location for the Siteman Cancer Center, and we'll talk a little bit about that later on. Now, those are the places where the residents train. Having said that, the faculty, the attendings, practice at these 5 additional sites. And it is very likely that over the years, we will add another resident and expand our residency training program to 1 or more of these locations. As of now, we are recruiting 4 residents per year. And after next year, we would have 4 residents in each of the 5 years that comprise clinical urology training. After that, we may very well expand to 5 residents per year, because even now we have sufficient patient volume for the sites where we presently practice. But as our practice at these other locations continues to grow, having additional opportunity to train another resident per year is something that I think we would very likely take advantage of. Speaking of patient volumes, here are some data from calendar year 2019, and here it is 2020. Now remember, we're not all the way through 2020, number one, and number two, we had this little thing called COVID that required us to slow down for about 2 months. So you can see on the adult side, there's about 29,000 patient visits a year, about 9,000 new patients, down a little bit, again, because of COVID, and we're not fully through the calendar year yet. This is called the Center for Outpatient Health. This is a resident-run clinic. There are faculty members that serve as the attending. You can see in 2019, 1,300 visits, about 300 new patients, and you can see what the stats are thus far this year. This is Children's Hospital, again, 2019 data, total number of visits, total new patients, and these are the data for 2020. I've been telling you about the VA and what an important component of the training program it is. You can see what the volumes were in 2019. We were not able to get any update thus far in 2020, however. Those are patient visits in the outpatient area. What about surgical cases? So you can see the case volumes in 2019. There were about 3,000 cases at Barnes Jewish Hospital. 500 of them were robotic or lap. And you can see what the data are thus far, year to date in 2020. Barnes West, a year ago, 1,200 total cases, 200 robotic and lap, and you can see where we are this year. Children's Hospital Northeast, about 450 cases, 36 robo and lap, and you can see the data this year. Actually a very big increase because we added a new faculty member, Ken Sands. Children's Hospital, again, 900 and some cases, 40 robot and lap, and you can see where it stands this year. And these, for the VA, we only have the 2019 data in those categories. We have all the technology you could possibly want. Many residents are interested in robots. We got robots everywhere. There are 3 XIs and an SP single port robot at BJH. All of these hospitals, with the exception of Children's in the VA, have a bedside first assistant and dual consoles. so the residents don't have to be relegated to be the bedside first assistant. They can be actively involved in the performance of the case from the second console. There's an SI robot at Children's. We'll probably be changing that out to an SP in the next couple of years. And you can see the other robots at the other hospitals. There's a lot of technology in urology, as you well know, and we have it all. Some of the more exciting things is the Moses laser for HOLEP and stone cases. We are on the waiting list to get a thulium laser, which is another highly valued laser for stone disease. This exact view micro ultrasound imaging system, I think, will make conventional transrectal ultrasound of the prostate obsolete. And we have our fusion platform using the UroNav or the Philips system. I have this little picture here. This is a PET MRI. We have a very, very strong imaging center, and we have access to some proprietary PET imaging studies for prostate cancer, for primary prostate cancer, not just metastatic prostate cancer. Now, doing a lot of cases is important, but doing the cases well is even more important in a way. And I don't know if you're familiar with this organization called Vizient. Vizient is an organization comprised of about 120 of the largest academic medical centers in the United States. And this was started 10 or 15 years ago when the hospital administrators wanted to know, well, gee, do I actually have a good urology service at Barnes Jewish Hospital? How does it compare to the other urology services at like institutions? So all of these institutions agreed to anonymize their data. They share it with Vizient. Vizient crunches the numbers, adjusts for all kinds of relevant variables and the like. And then they can report back to the hospitals so that the hospital administration and the leadership knows whether the urology service is any good or not. And so, for example, the three main categories they look at are length of stay, cost, and mortality. And the convention they use is to report it as the observed rate over the expected rate. So if you were an average hospital for length of stay, your O to E ratio would be 1. But if you're above average, your length of stay, as it is in our case, is only 72% of what it would be if we were average. So it's better that we get our patients out of the hospital quicker. Our cost structure is, again, better than average. We spend only 69% in taking care of our patients, as you would have expected if we were an average medical center. And our mortality is only about half of what you would expect it to be given our case mix. And you can get a lot of data here. So here's the rank order of urology services at comprehensive academic medical centers throughout the United States. And you can see we're in the 90th percentile with this cost O to E of 0.69. Many of the other hospitals have higher cost. And the same is true. You could drill down as deeply as you want into things like readmissions or length of stay, and you can slice and dice the data and compare your hospital to other highly ranked hospitals, and thereby see exactly where you stand and whether or not your faculty, trainees, et cetera, are doing a good job and learning how to do a good job when it comes to these variables. As I said, we could go down and get an individual surgeon's data in terms of length of stay and readmission and cost. We can do it for a specific operation, such as radical prostatectomy. And these data are really very powerful. We watch these data very carefully. We talk about them at the conference all the time. It's a very valuable thing for the residents to learn, because when you leave, when you go into whether it's private or academic practice, these data will be kept on you, and you'll have to, you should understand how these data are collected and how to do the best job you possibly can, how to put your best foot forward. Other measures of faculty productivity and quality are the number, well, of NIH grants. We have 14 NIH and federal grants, about 2.6 million a year, which would place us 8th among urology programs in North America. We have 65 presentations at major meetings, 87 peer-reviewed publications. A lot of these publications and presentations are made possible by our own urologic data repository. We've been keeping this now for about 20 years. We have many thousands of patients with a variety of diseases. We have a full-time statistician, 2 to 3 data abstractors at any given time, and a data manager. And there's, when it comes to be crunch time, it's an AUA abstract deadline or a World Congress of Endourology deadline, these people are available full-time to help us churn out our abstracts and later on to convert those abstracts into publications. It's a terrific resource, and you know, the interested resident who wants to write papers and do presentations can take full advantage of this, assisted, of course, by a faculty member. I like this little analysis here. Some years ago, some bibliometricians looked at the quality of publications that arise from various academic institutions. And so they just asked the question, what are the institutions that have the highest number of articles among the overall 100 top cited articles in all of urology? So you can see in 2009, when they did that analysis, WashU was 5th. When they redid the analysis in 2013, we ended up tied for 2nd with Harvard and Memorial Sloan Kettering for publishing influential papers in urology. So I'm really very proud of the faculty to not just publish a lot, but to publish quality papers. I alluded to this before. I'm a big believer in clinical trials. We have 8 nurses, nurse coordinators. You can see the group here, and they really do a lot of the IRB work and a lot of the background work in launching these, many cases, randomized clinical trials. We have close collaborations in oncology, nephrology, radiology, nuclear medicine, and we not just participate in a lot of clinical trials, but we lead a lot of important national and international clinical trials. And this is another skill that I think the residents should learn, or at least learn something about. Because you know, clinical trials are crucially important. They can serve as a differentiator of your practice versus the practice of the individual down the street. And they really do help patients because it gives them access to the latest technology, and in many cases, it pays for the care that they might not otherwise be able to receive. So that's my introduction to urology at Washington University in St. Louis. Dr. Traxel will be detailing more about the residency itself. I'll just leave you with the final little point that I like a lot about WashU. Our logo are these 3 words inside this book, per veritatem vis. Though that motto means there is power, vis, through truth. So that's what we strive for. We strive to learn the truth, and once you have truth, you can be a powerful source for disseminating urological information and urological education. So thank you very much for listening. I really look forward to meeting you all later on in our Zoom interviews. Thanks again.